Hello, everyone, and welcome to week 7 Substance Use Disorders. Just a little bit about prevalence. 11.7% of Americans 12 and over use illegal drugs. If we include alcohol and tobacco, it's 165 million, or 60.2% of Americans ages 12 and up currently abuse drugs. It can be co-occurring with mental illness in up to 5 to 10 million adults. And, 50 to 75% of those in substance abuse treatment have a co-occurring psychiatric diagnosis. This is a famous actor, comedian Russell Brand. He's a recovery advocate for recovering from his own addiction. Talks about cannabis, how it's not a gateway drug. Alcohol isn't a gateway drug, but if you keep reading, it talks about how trauma is and molestation is and neglect. And I have seen that in my patients. I have the privilege of caring for substance abuse patients, substance use disorder patients, and um, I do find it very rewarding. But I can tell you, most all of them have had significant trauma in their childhood. Some theories of addiction. Dopamine theory. Dopamine equals pleasure. It's a pleasure neurotransmitter. Alterations in dopamine may affect response to certain drugs. The gateway hypothesis, which has been debunked. Genetics can play a part. Environment, i.e., nature versus nurture. And remember, there's no such thing as an addictive personality. Um, we can become addicted through behaviors and practice and use of things. So, some terminology addiction, it's a treatable chronic and complex medical disease. People engaging in compulsive behaviors despite harmful consequences. And addiction is not a DSM-5 term. Instead, use a specific substance use disorder with severity qualifier. Very important to remember that. Dependence, it can be um, psychological, using more of a drug to achieve the same pleasurable effect or high, or physiologic, using more of the drug to avoid withdrawal symptoms. And withdrawal is the body's response to being without the substance. And who is this gentleman here? Well, this is Bill Wilson, one of the two founders of Alcoholics Anonymous, which is a great program. And if you are doing substance use disorder, I would encourage you to have all of your patients be involved with this. I do hear patients tell me that they feel like it's too religious or something like that sometimes, but this program is proven and it works for people. So, alcohol use disorder. 6.3% of adults report heavy drinking. This has increased since COVID. 9.8% of adult deaths are attributed to alcohol. Some screening. There's your CAGE and your audit um, screening tools. Some labs you can do. You don't just diagnose on lab work, though. So, however, it can provide some strong clues, liver enzymes, including your GGT or gamma glutamate transferase, your CBC with MCV and platelets, looking at that, drug screen for co-occurring use. And how do you treat withdrawal then? Well, strongly recurred and discouraged from treating in an outpatient setting. Why? Because people can die. It's a real thing. So I would really always encourage someone to go inpatient for alcohol withdrawal. It can be fatal. It can cause seizures, delirium tremors, very uncomfortable. So there are two approaches. There's a symptom-based approach where they do treatment based on symptoms, and then gradual taper. And your COA, which is used often inpatient, the Clinical Institute of Withdrawal Assessment, gives numerical values for severity. Benzodiazepines are typically used to treat withdrawal symptoms. You see those listed here. And what are withdrawal symptoms? Well, they're the central nervous system's response. Um, to withdraw from a substance. So you have nausea, vomiting, tremor, anxiety, agitation, tactile disturbances, auditory disturbances, visual disturbances, you name it, they're here. They can have elevated heart rate, pulse, temperature. So how do we treat alcohol use disorder? Well, naltrexone, Vivitrol, which I use a lot in my practice, it blocks opiate or pleasure receptors. Um, the injection you get once a month, or there's also oral naltrexone, which is daily that they have to take. Um, be mindful that they cannot continue to drink while taking these medications because they will not become intoxicated and will continue to drink and cause a lot of harm to themselves. Anti-abuse, that's aversion therapy, inhibits aldehyde dehydrogenase. People will vomit and get very sick, um, even with mouthwash or perfumes, anything with liquor. They will be sick. I'm sorry, with alcohol. They will become very sick. Camprol or acamprosate modulates glutamate. Um, it's a good alternative if naltrexone is not an option. They do have to take 3 times a day, so I don't know. It might be difficult for patients to adhere to that. And then Topamax is used, and gabapentin. I often use this in conjunction with naltrexone or Vivitrol, but it is off-label, but it can be helpful. So long-term effects of alcohol abuse. Typically, alcohol affects 1 to 2 body systems, and not everyone will have liver impairment. So there's increased risk of cardiovascular disease, fatty liver, cirrhosis, anemia, pancreatitis, fetal alcohol syndrome, brain dysfunction is a big one, chronic seizures, neuromuscular impairment, malnutrition, rosacea, increased risk of cancers, so many things from alcohol abuse. Benzodiazepine addiction. And again, I've cautioned you previously, be very, very careful with the prescribing and use of benzodiazepines. And if you happen to inherit a patient who's been on them long term, start to work with them to get them off of those substances. So we know that they cause CNS depressant, and then withdrawal can cause CNS activation. You can't just stop these medications because it can cause death. It can have seizures. So they have to be weaned down. Um, and it's our responsibility, like I said, to prescribe judiciously. Um, check your state's PMP as often as possible to make sure they're not getting other medications. But don't, again, be afraid to use them. Just be cautious. Don't overprescribe and don't underprescribe. All right, so stimulants. This is your methamphetamines, your amphetamines, but can include ecstasy, crystal meth, ice. Um, there's a psychological and physiological addiction here. Again, checking your state's PMP. Careful of assessment of ADHD. Do they meet the criteria? Make sure that it's validated. Nicotine. If you have patients with a mental health disorder and they also smoke, I think you should be counseling them on smoking cessation. Also, want to use your diagnosis, put in there tobacco use disorder, and that you've counseled these patients on, if you do, which you should, on tobacco cessation and nicotine cessation. So vaping is increased dramatically. So especially in young people, smoking, there's chewing, there's pipes. And different methods here you see listed. Smoking and mental illness. Well, although only 25% of adults have a mental illness, these same adults consume up to 40% of all cigarettes. And smoking is still allowed in some psychiatric facilities, um, but many don't. Where I work, they don't allow smoking. Data shows that anywhere from 75 to 90% of people with schizophrenia smoke. And the smoking is a leading cause as to why people with mental illness die at a younger age. So always counsel those patients uh, to work on quitting and offer ways to help them, nicotine patch or gum. Um, and as I share here, it's a myth that people with mental illness should not or cannot quit smoking, and also a myth that people with other co-occurring addictive disorders should only quit one substance at a time. Tobacco use disorder, at least two symptoms for 12 months, used in larger amounts than intended, persistent desire, effort to cut down, great deal of time spent using tobacco, there's cravings, recurrent use, um, engaging in activities that are dangerous while using, like smoking in bed, tolerance, withdrawal. There's some nice pharmacologic options for smoking cessation. You have your nicotine replacement, your patch, your gum. Um, Chantix is a good option, but it can have some psychiatric symptoms, so be very careful. Wellbutrin works well for many patients, but be mindful of its psychiatric effects on mental illness. Other drugs of use are cocaine, hallucinogens, and cannabis. I also often will put cannabis use disorder for my patients who smoke cannabis, which is a lot of them here in the state of Michigan. It's legal now, so there are quite a few patients that do smoke cannabis. And I want to clarify some terminology here. So, an opiate, it's a naturally occurring substance made directly from the opium plant, such as morphine, codeine, heroin. An opioid is a synthetic or partially synthetic substance, such as hydrocodone, oxycodone, fentanyl, methadone, and a narcotic typically refers to any opiate. However, in legal circles, it may be the term used for any illicit substance. Opiates. Two great books here. If you like to listen to books or like to read, I recommend both of these books. They're excellent on substance use disorder. Um, on average, 130 people die every day from opiate overdose. The current opiate epidemic is felt to have occurred in three waves in the 90s, and then later in 2000s, and then, as you see here in 2013 and beyond, fentanyl began to make a rise. And as I shared a little bit earlier with COVID, there's been a significant increase in death in opiates. And I think I was just reading in 2020 alone, some of the highest death rates from opiates the highest death rates from opiates that we've seen. It was considered a national emergency. Assessing for opiate abuse. Well, lab work. You're doing your physical assessment and checking for check marks, pock marks of the skin, dilated, watery eyes, runny nose, yawning. See that a lot. Muscle pain, GI upset. Other clues. You want to normalize but not sensationalize. Be non-judgmental. Ask how they obtain their drugs. Are they, engaging in criminal behavior, prostitution? And assess for readiness for change. And consider risk reduction strategies. Do you need to give um, nasal spray to help with any over addiction or anything like that? Medication assisted treatment, MAT. Again, you have your naltrexone. May not start this while on opiates. Methadone is a long acting opiate agonist and is only administered in closely controlled settings. So you probably won't be prescribing this unless you're working in a methadone clinic. Buprenorphine or Suboxone, Subutex, and there's Subucade now, which is an injection. I forgot to include that. I apologize. There's a buprenorphine training that you'll be doing this week. This is a partial opiate agonist, and it's no longer restricted on prescribing, so anyone can prescribe this now. And there's naloxone, Narcan, that I was saying. That's the There's a nasal spray that works well. There's also an injection, but the nasal spray works well. It's an opiate antagonist, a reversal agent. And yes, you should prescribe this with all of your patients who are at high risk. Um, you want to give this to them, give them a script for them. Some pharmacies were giving this out free. So even if they're on Suboxone and in treatment, you still want to make sure they have this and keep that with them, keep that close by. Some clinical pearls then when caring for this population. It's very rewarding, I think. Um, but remember, you want to have unconditional positive regard and leave any biases at the door. Education, you may not use any opiates if on MAT. Well, that doesn't always happen. Remember, there's a recovery, there's a road, there's going to be ups and downs, and tolerance will vary. It's important that patients understand that following detox, their tolerance will have decreased. I always remind patients of that, so they can't go back to using what they were if they decide to. Um, and it could be fatal. And we've seen that happen in the news, and many people have accidentally overdosed, thinking they could use the same substance that they were in the past. Assessing for substance use disorder, kind of a brief framework. Nicotine, do you smoke? Do you vape or juul? How much? For how long? Have you ever tried to quit? Alcohol, do you drink alcohol at all? How many times per month, per week? What type of alcohol do you drink? How many drinks at each setting? Um, is it a glass of wine or is it a bottle of wine? I recently had a patient who admitted to me that she was drinking a bottle of wine a night. And that was a problem. We got her some help. Cannabis. Do you ever use marijuana? How often? Um, I have many patients who smoke this multiple times a day, and that is a real problem. Illicit drugs. So don't use the word illicit. Do you ever use or buy anything that are given from others? Do you use prescription medications belonging to other people? And then caffeine. Remember that caffeine can mean addiction. Some treatment options. There's acute inpatient, only appropriate those in which withdrawal can be life threatening. Outpatient. So you have multiple programs for that. This can include methadone, buprenorphine, residential treatments. They have 28 days, 90 days. They have group homes, support groups. Very important. Anyone in recovery needs to be in therapy and they need to be going to AA or NA. In fact, I would insist that they do to be part of a program. They have to be in therapy, going to groups, be engaged in their recovery, um, because that's part of the process and that's part of helping them stay off of substances. So, in summary, about 1 in 4 persons with a mental illness also have co-occurring substance use disorder. The DSM-5 criteria for substance use disorder is very similar. The substance has extensive negative impact, significant time spent obtaining or using, and use continues despite consequences. Inpatient detox may be needed for some substances, but not all, and recovery is possible. And remember, we didn't touch much on this, but methamphetamine abuse has been increasing. There is really no treatment program, no treatment as far as medication for that yet. They are working on that. There's studies going on right now, but there are treatment programs, inpatient treatment programs for that, not generally covered. Um, which is unfortunate, but you will see a lot of methamphetamine abuse, unfortunately, use going on. Um, when I'm working in the inpatient setting, I frequently have patients who come in with methamphetamine psychotic disorder, use disorder. Um, they become psychotic as a result of their abuse of methamphetamines, and that's increasing as well. So just be mindful of that. So we're almost done. It's been a pleasure working with all of you. You've got that this week, your buprenorphine training. Take time for yourselves to refresh, collect yourselves, review past lectures. The final exam is going to be cumulative over all materials. I think you'll do fine. And it's been a pleasure working with all of you. And I wish you guys continued success. And I believe you're going to be great PMHMPs. Take care.